Hey guys, welcome to another session. Let's continue our journey through alimentary canal. Right? Today, as we already have a general view of large intestine, we'll deal with the particular parts. Right? Today, we'll discuss about the cecum with appendix. Right? Cecum is a large dilated blind sac at the commencement of the large intestine. It is situated in the right iliac fossa above the lateral half of the inguinal ligament. We'll see that. So the selected structure is the cecum. It is blind because here you see here it is ended, right? So it is blind. Here you can see appendix. And it is situated in the right iliac fossa, right? So you know the 9 quadrants, right? So it is situated in the right iliac fossa, right? So if we start drawing, so this comes to the right iliac fossa. Its surface projection occupies the triangular region limited by the right lateral plane, the transtubercular plane, and the inguinal ligament. Okay, this is, you have learned these things in the previous classes, right? So let me show you. Okay, in the previous classes we have known that midclavicular plane, right? Midclavicular plane. Sorry, this is the midclavicular plane, and this one again the midclavicular plane, right? And this one transtubercular plane, because tubercle of the ileum, and this one being subcostal plane. These are the imaginary lines, right? And so, and if the inguinal ligament is present here, right? So the cecum is, the umbilicus is here. Cecum is at the, this transtubercular plane, this is right one, and this one is left one, right? So what happens is this this midclavicular line is also called as right lateral plane. So this part is in at the junction of the right lateral plane and transtubercular plane, right? So is the location of the cecum and also the location of appendix also, right? Okay. So that is the triangular region. In the triangular region, cecum presents. It communicates superiorly with the ascending colon, medially at the iliacal junction with the ileum, and posteromedially with appendix. Okay, let's clear them. So superiorly, it communicates with the ascending colon. That is the ascending colon, and this one is the ileum, right? And this one, and posteromedially, this one is the appendix. So this is posteromedial. So these are the communications. Coming to the shape, it's a dilated pedunculous sac inferior to the ileocecal junction. So the point where ileum, you see the point where ileum communicates with cecum is called as, so this one is called as ileocecal junction, right? The growth of cecum from birth leads to a change in its shape and in position of the attachment of appendix. At birth, cecum is conical in shape and vermiform appendix is attached at its apex, right? It's like that. A simple drawing. Later on, sacral growth results in the formation of two sacules, right? One on either side of anterior tinea coli, right? On either side of anterior tinea coli. So the growth of right sacule is greater than the left. So right one, anterior tinea coli, left one, right? So that the appendix of cecum and the base of the appendix are pushed towards the left and nearer to the ileocecal junction, right? That is the region. As a result, the base of appendix is attached to the posteromedial wall of the cecum, right? That is the developmental part. Coming to the types, the variations. The cecum and a vermiform appendix develop from cecal bud arising from the caudal limb of the primitive intestinal loop. The proximal part of the bud dilates to form cecum, and the distal part remains narrower and forms the vermiform appendix. We have seen this in our developmental class. On the basis of growth of the cecum later on, 4 types of cecum may be found in adults. Conical type, cecum is conical and the apex is attached at its apex, appendix. Infantile type, the cecum quadrate in shape, the appendix attached at the depressed bottom. And normal type, the right sacule is larger, right one is larger than left one, and apex is attached to the posteromedial aspect, about 2 cm below ileocecal junction. Exaggerated type is the right sacule is immensely large and the left is absent. Okay, right only. So this is the conical shape. Immediately below appendix is immediately below cecum. This is quadrant in shape, and this is the normal. Okay, large left, right greater than left, and here there is no left, only right. The cecum is 6 centimeters in length and 7.5 centimeters in width. Cecum is one of those organs of the body which have greater width than length. Example: prostate, pituitary, isthmus of thyroid, and celiac trunk. Coming to the relations. Visual relations: anteriorly the coils of small intestine, greater omentum, and anterior abdominal wall. You can see that. So this is greater omentum, this is caecum. So this is anterior relation, and these are the coils of intestine, right? Jejunum and ileum lies anterior to the caecum. So this is caecum. See, these are the anterior, freely mobile, right? Coming to the posterior. Posteriorly, right psoas major and iliacus muscles, femoral nerve, lateral cutaneous nerve of the thigh, and genitofemoral nerve of the right side, right gonadal vessels, right external iliac artery sometimes, and retrosacral recess. So coming to the posterior relationship, see, so this one is psoas major, see, that is psoas major, right? I will, okay. Okay, so psoas major is all the way, it is related to the caecum, right? And this muscle is iliacus. And also, the caecum is related to, this is the femoral cutaneous nerve of the thigh, this one being the femoral nerve. You know those things, right? This is femoral cutaneous nerve of the thigh, femoral nerve, and this one being genitofemoral nerve. So all these things are, I will do one thing. See, so all the nerves are related to the caecum, and also the gonadal vessels. See, testicular artery, testicular vein, or ovarian artery and ovarian vein. Okay, lies related to the caecum. So those are the posterior relations. See, right? See, this is the diagram. Peritoneal relationship. In about 90% individuals, the caecum is almost completely surrounded by peritoneum and has wide retrosacral recesses which may ascend up posterior to the lower part of the ascending colon and then called retrocolic recess. The vermiform appendix frequently lies in retrosacral recess in 10% of individuals. The upper part of its posterior surface is non-peritoneal and lies directly on facial atom. The other recesses in the ileocecal region are superior ileocecal recess underneath the superior ileocecal fold and inferior ileocecal recess underneath the inferior ileocecal fold. We'll see that. Superior ileocecal fold. It lies between the ileum and ascending colon. It's a fold of peritoneum from the posterior abdominal wall raised by anterior cecal artery. Therefore, it is called as vascular fold of caecum. It guards superior ileocecal recess and opens downwards and to the left. Coming to the inferior ileocecal fold, it extends from anteroinferior aspect of terminal part of ileum to the caecum or appendix. It does not contain any blood vessels, so called as blood vessel fold of Trevis. It lies in front of ileocecal recess which looks downwards and to the left. Caecal fold lies on the posterior surface and forms the right boundary of the posterior ileocecal recess. Okay. So this is anterior caecal artery. Okay. So this peritoneal attachment is called as this peritoneal attachment. Superior ileocecal fold. Right. So the space beneath this fold is called as superior ileocecal recess. And this fold is called as, this peritoneal reflection is called as inferior ileocecal fold, and the space beneath this is called as inferior ileocecal recess. Right? Simple. And this is retrocecal, means behind the cecum. This is retrocecal recess. Appendix is lying in the retrocecal recess. This is most revealing. You see the peritoneal folds along with the fatty layers. So these are the branches, right? Sacral branches. So this one, the recess is superior ileocecal recess, and this recess is inferior ileocecal recess. Okay, so this fold, peritoneal fold, inferior ileocecal fold and superior ileocecal fold, right? Coming to the interior. Interior of the cecum presents two orifices, ileocecal orifice and appendicular orifice. Ileocecal orifice is present on the posteromedial aspect of the cecocolic junction, where the ileum opens into the large intestine. The orifice measures about 2.5 centimeters transversely. The orifice is guarded by a valve called ileocecal valve. The valve has two lips, upper lip and lower lip. The upper lip is smaller and horizontal. It lies at the level of ileocolic junction, that means at the junction of ileum and colon. The lower lips longer and concave upwards at the level of ileocecal junction, right? That means ileum and cecum. Okay, you know the difference. Ileocolic means at the ascending colon, right? The two lips meet at the ends and are continued as the mucous folds called frenula, which may act as a cecocolic sphincter. Each lip is made of thickening of circular muscle cord covered by its submucosa and mucosa. The ileocecal valve regulates flow of contents from the ileum to cecum and prevents regurgitation of contents of the cecum into the ileum. You see, this is the upper lip, horizontal one, and this is the lower lip, concave. So the upper lip is at the junction of ileum and colon, ileocolic junction, ileocolic. Lower lip is at the junction of ileocecal, right? Ileo. So this is ileum, this is cecum, this is ascending colon, right? So that is ileocecal junction, and this orifice is appendicular orifice. Okay, appendix also opens into the cecum. Okay, this is peritoneal relations. You see, that is ileocecal junction, right? So that is happening, opening at the posteromedial junction. Okay, posteromedial, you can clearly see that. And also appendix also opens into the cecum. Those are the two orifices interiorly. You see, this fold horizontal, concave. So the horizontal one, this is ascending colon. You see, ascending colon. So at the ileocolic junction, this is at the ileocecal junction, right? And this is orifice of appendix. Okay, you can clearly see that. Go through the diagram. And this one, endoscopic appearance. Okay, bilabial structure. Right. Coming to the appendicular orifice, 2 cm below and slightly behind ileocecal orifice, guarded by insignificant semicircular fold of mucous membrane called wall of Gerlach, attended to the lower margin of the opening. The cecum is supplied by the anterior and posterior cecal branches of ileocholic artery, a branch of superior mesenteric artery. The veins of the cecum follows the arteries and drains into the superior mesenteric vein, which drains into the portal vein. Lymph vessels from the cecum drains into the ileocholic lymph nodes, which turn drain into the superior mesenteric group of. Okay. So this one being superior mesenteric artery. Okay. These are its branches. We have already know that. So those are the jejunal and ileal branches. Okay, I'm adding them. Okay, so this is the right colic artery, a branch of superior mesenteric artery, and this one ileocholic artery, right? Ileocholic artery has two branches, right? Ileal branches and colic branches. Ileal branches supplies ileum and colic branches supplies cecum, right? So this one has ascending and descending, right? So cecal arteries, branch of ileocholic artery. Nerve supply is by T11 and L1 spinal segments from superior mesenteric plexus and also parasympathetic by vagus. Coming to the vermiform appendix, which is attached to the cecum, right? Vermiform appendix is a narrow worm-like diverticulum which arises from the posterior-medial wall of cecum about 2 centimeters below ileocecal junction. Varies in length 2 to 20 centimeters, average is 9 centimeters. Average width is 5 mm. The diameter of lumen varies with age. It is more in children than adult and often obliterated after mid-adult life. Okay. The length also varies with age. It's longer in children than in adults. Coming to the part, it has three parts: base, body, tip. The base is attached to the posterior medial wall of the cecum, 2 centimeters below the ileocecal junction. All the three tinea of cecum converge at the base of appendix. You have seen that. You see, this is the appendix, right? Selected structure is appendix opening to the posterior medial aspect of the cecum. And this is the tinea, anterior tinea, and these are the medial and posterior tinea. All these converge at the appendix, right? So, you see, along with tinea. The anatomical fact serves as a guide to the surgeon to search for the appendix during appendectomy. The body is a narrow tubular part between base and tip. The tip is the least vascular distal blind end. It may be directed in various directions. Surface anatomy. The base of the appendix is marked on the surface at 0.2 centimeters below the intersection between the transtubercular plane and the right midclavicular plane, right lateral plane. We have already seen this, right? So this is the right, and this is the left lateral plane or midclavicular line, subcostal plane, transtubercular plane, right? At 2 centimeters below the intersection of transtubercular plane and midclavicular plane. Okay. So this is the intersection of transtubercular plane. Okay. This is TT plane and this one is midclavicular plane. So appendix lies 2 centimeters below. The base of the appendix lies 2 centimeters below the intersection of transtubercular plane and midclavicular plane. Okay, that is the usual. The point representing the base on the surface and McBurney's point do not exactly correspond anatomically, but they are in close approximation topographically. For this region, clinicians equate the surface marking of appendix to McBurney's point. You have already learned about McBurney's point, right? The junction, McBurney's point. Let me draw. McBurney's point is this is umbilicus plane going from okay. This one is McBurney's point, right? Base of appendix, see, lateral 1/3, middle 1/3, proximal 1/3. The surface projection of base of appendix is at the junction of the lateral and middle 1/3 of a line from anterior superior iliac spine to umbilicus, right? See, this is a line from anterior superior iliac spine to umbilicus, and if we divide them into lateral 1/3, middle 1/3, okay, so this is the proximal 1/3, medial 1/3, and lateral 1/3. So this lies, appendix lies the junction of lateral 1/3 and medial 1/3, 2 centimeters below this junction, right? So this one is appendix, you can clearly see. Okay, this is appendix. So this point is called as McBurney's point, right? So that is McBurney's point, right? Positions. The appendix usually lies in the right iliac fossa. The base of the appendix is fixed, but remaining part may occupy any of the following positions, which are often indicated with an hour hand of a clock. Paracolic or 11 o'clock position, the appendix passes upward on the right side of the ascending colon in 2% of the cases. Okay, that is paracolic. Retrococcygeal or retrocolic, appendix passes upward behind cecum. Okay, this is the normal commonest position, okay, behind cecum. Splenic, the appendix passes upward and medially in front of or behind post-ileal or pre-ileal, the terminal part of the ileum. The tip of appendix points towards the spleen. That is why it is called as splenic or 2 o'clock position. The pre-ileal position is the most dangerous because inflammation sets in the peritoneal cavity. Right? Promontoric, that means towards the sacral promontory, and pelvic. The appendix descends downward medially and crosses the pelvic to enter the true pelvis. In females, it may be related to the right uterine tube. Second most commonest position, right? Pelvic. Mid-inguinal or subcecal, 6 o'clock. The appendix passes vertically downward below cecum and points toward the inguinal ligament, right? That is subcecal. You see? So this is ileum. Before ileum is pre-ileal, behind ileum is post-ileal, okay? This is retrosacral, that is behind cecum, right? So that is the 12 o'clock position. Paracolic, 11 o'clock position. This is subcecal, right? This is splenic, right? Promontoric, 3 o'clock position. And this is pelvic, 4 o'clock position. Okay? Retrocolic, subcecal, pelvic, pre-ileal, post-ileal. Okay, depending on these positions, the clinical symptoms of appendicitis occurs, right? So whatever the related part is to the inflamed appendix, we get the symptoms. Subhepatic appendix. It's normal position of appendix in which it lies underneath the liver in the right hypochondria. It's abnormal position, developmental anomaly. Okay. So the inflammation of subhepatic appendix causes pain and tenderness in the right hypochondrium and may mimic acute cholecystitis. Right? Actually, it is appendicitis, but mimics acute cholecystitis. See, subhepatic developmental anomaly. Peritoneal relationship. The vermiform appendix is an intraperitoneal structure. The appendix is suspended by a small triangular fold of peritoneum derived from posterior left layer of mesentery called as mesoappendix. Right? We have seen that appendicular artery runs within the free margin of mesoappendix. Appendix is supplied by a single appendicular artery, a branch of inferior division of ileocolic artery. This passes behind terminal part of ileum to enter the mesoappendix and runs in its free margin. Right? The appendicular artery is an end artery. In appendicitis, this part of artery is affected and thrombosed because it is an end artery, right? It is an end artery and there are no anastomosis. So leading to gangrenous change in the tip which may perforate. This is the most dangerous thing in the appendicitis. See, so this one being the ileocolic artery, right? Branch, colic branch, this is ileal branch. Colic branch has ascending and descending, right? Descending has anterior and posterior branches, right? And this one is appendicular artery. Appendicular artery. You see? Venous drainage, they drain into superior mesenteric veins, which ultimately drains into portal vein. The sympathetic nerve supply, which carries the pain sensation from appendix, derived from T10 via lesser splanchnic nerve and superior mesenteric plexus. For this region, the pain of appendicitis is referred to the umbilical region at first. Parasympathetic is by varus. Coming to the appendicitis. Right? Inflammation of the appendix is called as appendicitis. Acute appendicitis is a common occurrence and is a surgical emergency. It occurs due to obstruction of lumen by fecalith or edema. Initial pain of appendicitis is referred pain and is felt in the umbilical region because both have same segmental nerve supply, right? T10. That is why first the pain is at the umbilical region. Gradually, it localizes to the McBurney's point. Gradually, the pain is localized in the right iliac fossa, especially at the McBurney's point. It is due to involvement of local parietal peritoneum. The overlying musculature undergoes spasm, causing guarding of the anterior abdominal wall. This is a clinical observation. On palpation, maximum tenderness is elicited at the McBurney's point, which is marked on the surface by a point at the junction of medial 2/3 and lateral 1/3 of line extending from the umbilicus to the right anterior superior iliac spine. A Soyer's test in appendicitis. When the appendix is retrocecal in position, retrocecal means behind the cecum. So it is related to posterior relation of the cecum is psoas major. So if the appendix lies behind the cecum, right, it comes in contact with the psoas. It lies and irritates the right psoas major when inflamed. I can show you. So we are talking about retrocecal position, right? This is the cecum. Cecum is retrocecal like this, right? So it is directly related to psoas major. That is called as psoas test. Obturator test. So what happens is the forced extension of the right thigh in such patients cause increased pain in right iliac fossa, right? So the obturator test means when the appendix is pelvic in position, it may irritate the obturator internus muscle, right? The flexion and medial rotation of the right thigh on the abdomen causes pain on the lower abdomen. So these are the clinical tests you elicit whether to know it is appendicitis or not, right? When the appendicitis is acutely inflamed, it will be removed by the surgeon called as appendicectomy, right? So that is about cecum and appendix, right? So if you have any doubts, let me know.